Good evening, everyone. Thanks so much for joining us. We'll be getting started in just a couple minutes. Hang tight and we'll get started very soon. Hi, everyone. Thanks for joining us tonight. We'll be getting started in just a moment. Good evening to all of you. A warm hello and aloha. And thank you so much for joining us tonight for Ask Me, our educational webinar series. My name's Audra Hines, Vice President of Care Services for the Golden West chapter of the ALS Association. We absolutely could not make programs like this one tonight possible without generous donations to the Golden West chapter. I want to thank our lead sponsor for the Ask Me series, Mitsubishi Tanabe Pharma America, as well as our special donors, including the Ron Malone family and the Morris family. We're truly, truly grateful for these tremendous contributions from our strong partners and amazing individuals and families like these. As a person living with ALS, or as someone who loves and cares about someone with ALS, we know that new symptoms and challenges related to the disease arise on a daily basis. It's critical to have the right people providing the right information that's easily accessible, including the most qualified care team, in order to adequately navigate a variety of changes. You'll hear from a specialist from one of the chapter's certified centers tonight. And our talk tonight is focused on respiratory care related to managing ALS. Respiratory issues can easily be one of the most challenging and frightening symptoms of this disease. When you need to meet other people who are managing this disease too, and may have as many questions and concerns as you do, we're here to help. The Golden West Chapter Care Services team is here to offer information and referrals as you need them related to finding the best care to manage these issues. To learn more about the chapter and the multitude of services we provide, please visit alsagoldenwest.org for more information. And in collaboration with one of the chapter's ALS certified treatment centers, we could stop sharing that slide, Loma University Medical Center, tonight we're bringing a presentation and discussion to you on this very important topic to many people living with ALS. Our team often receives questions about respiratory issues in ALS, including when to consider using a ventilator, how will I know when to do that, what type of specialist should I see? And in order to provide some clear direction and guidance on this subject, as well as answer many of your questions, tonight we've invited the respiratory therapist from Loma Linda's ALS clinic, Andrea Eddleman. I'm thrilled she could join us tonight on this really special topic. Andrea, thank you so much. If you want to pop onto camera and your sound, I will have you take it away.
Thank you, Audra. Thank you for that warm welcome. I'd also like to thank Golden West Chapter for this beautiful opportunity to be present with you all this evening. Thank you so much.
Thanks for being here.
Okay. So as she introduced me, my name is Andrea. I work at Loma University Health. I'm a neurorespiratory specialist on a multidisciplinary team. We're a full-time team dedicated to neuromuscular disease. It's something I'm very passionate about, and I'm excited to talk to you this evening. Tonight's agenda is going to consist of ALS spectrums. When we talk about bulbar present, upper motor neuron disease, lower motor neuron disease, I'd like to take you kind of through the channels of how we interact with you the day you're diagnosed, all the way up until those really hard life choices. I think I want to talk about how important it is to have routine visits and the constant changes and forever evolving respiratory needs that come on a day-to-day basis with neuromuscular disease. And then I also want to talk about caregivers and advocations and how we can help them guide
Andrea,
you.
We can't see your presentation yet. I'm not sure if you're sharing it.
Oh, okay. Hold on one second. I'm so sorry.
That's okay.
One second. Give me 1 second. There we go. Can you see everything okay, Audra? Is that good?
Yep, that totally works.
I apologize. I'm so
no
sorry.
worries at all. All good. Thank you. Perfect.
So here we go. Back again. As discussed, I am a neurorespiratory specialist out of Loma Linda. Our agenda this evening is going to consist of the different spectrums of ALS, the day they're diagnosed, the end-of-life care and options. I want to talk about routine visits and changes and how respiratory care is forever evolving and it's a constant pattern, so it's important to have those. And I also want to talk and advocate about big personal life decisions that you may have. And then, of course, we'll go over a Q&A at the end. So before we get started, I just wanted everyone to keep in mind that I come from a very positive, proactive team here at Loma Linda, and we want you all to know that in our hearts, we think ALS is treatable. We may not have a cure, but we do believe with every symptom, every cause, we can treat that symptom and cause with hopeful alternatives. So we really like to have a proactive perspective when it comes to treating ALS, and we do believe that no two people look the same. So just like autism has a large spectrum, we like to think that we treat the individual and not the disease. So we always keep a positive mind so that way the body can follow. And the best way to do that is to get started. The way to get started is to quit talking and begin doing. So Walt Disney, I'm actually going to Disney World tomorrow, so I wanted to throw that in there. So here at Team CRN, we always provide a hopeful alternative. We are the Center for Restorative Neurology. We're a full-time dedicated team, as I had mentioned, with a neurologist, a physical therapist, an occupational therapist, a speech-language pathologist, a respiratory care practitioner, which is myself, a counselor, and a dietitian. So a lot of people ask, do I really need a multidisciplinary team? The importance of a multidisciplinary team is because we integrate care with one another. We make a whole man kind of whole when we take a strand or a string and we link those together to make a strong rope, which we would use as an analogy to your care plan. So, you know, with speech, you may have respiratory issues. With dietitian, you might be lacking hydration, which affects your respiratory tract. PT, endurance, you got to breathe. So we really work together as an integrated team to kind of give you the best game plan for your care. So talking about a proactive approach, your visits need to be routine once every 3 months, if not sooner. You need to get involved, get into a multidisciplinary team, and that's your first visit. It's kind of a long day and it can be overwhelming, but when you have that camaraderie and that consistency of being on a multidisciplinary team, I really do think that the care evolves and it really, really helps. So with that said, your first visit, we get introduced. Typically your second to fifth visit, I'm going to have you on breathing exercises, bronchial hygiene regimen, because we never want to say I could have, would have, or should have done something. We're going to be very, very proactive, okay? Especially when it comes to the importance of respiratory care. And then by your third or ninth visit, yes, you should have a BiPAP or an NIV with the goal to wear those every night, and PEG placement needs to be discussed, okay? Now, of course, this is a vague overview of visits because based on your presentation, we're going to tailor those visits to each individual. So we have brought up recently the idea of having possibly different diseases. Although we categorize ALS, we have a huge umbrella of many different presentations. Those presentations typically start with bulbar weakness or bulbar onset ALS, where you'll notice choking on solids or liquids, a possible change in your voice, a change in the sound of your voice, maybe some cognitive impairments. You may have direct decision-making without logical thinking sometimes. Pseudobulbar effect is something we like to talk about, where emotions can be really high and really low. But true bulbar ALS weakness is tongue weakness. Any other neuro disease that we typically see, tongue weakness is our tall tale sign that it's a possible evolving motor neuron disease, okay? And then we have upper motor neuron disease where there's stiffness, spasticity, increased tone and reflex. You'll hear something of PLS. That's typically a subcategory, remember, in that spectrum of motor neuron disease. The upper motor neurons are in the cerebral cortex and the brain. It affects your gait with long strides, ataxia, and your posture will change a lot sooner. With lower motor neuron, you'll typically see muscle wasting, muscle weakness, short strides in your gait. This is affected through your spinal cord, and you'll have decreased tone and reflex, and your postural deficit will come much later, okay? So, routine testing. It is important with respiratory care, it's important with respiratory care that you have routine spirometry tests. You can do upright tests or supine tests where you lay flat. The rule of thumb for Medicare guidelines, which is kind of unfortunate because a lot of us have to have a breathing capacity less than 50% to get on a BiPAP or an NIV. And I'm going to talk to you later on in this presentation on how important it is to get on those sooner than later. If you're going to a multidisciplinary team, tell them you want to do your spirometry tests laying flat, because those numbers will help you get to that 50% sooner if need be. And there's other testing that respiratory could possibly do to get you those equipment sooner than later, because we always want to be one step ahead of the disease. Now, peak flow is another way that we can design testing, especially a cheap way. If you're in the Hawaii states and you're not in a local area, a peak flow meter can cost $10. I've had my also rep purchase them, and she supported us. And it's a cheap plastic test, but that peak flow typically used to measure asthma can tell us a lot about our ALS patient, especially with COVID. Those were nice to have. And then sleep studies should be done annually. I feel like a lot of our muscular dystrophies and stuff like that, those patients that are on ventilators, they get, when they're in their pediatric unit or they're up until 24 when the CCS cutoff is, they typically get annual sleep studies. It is so important because the disease is forever evolving that you get those studies done, so we make sure that we're on the right track. And then you can also get arterial blood gases. Those can be painful. An arterial blood gas is a blind stick by a respiratory therapist, typically in your wrist or your brachial, and that tells us the acidity levels in your body. You're going to hear a lot about CO2 numbers in your body. And those are huge. Those two numbers can really determine if we're on the right track with your respiratory care. But because they're painful and we have alternative ways of testing those or recognizing those, I try to subside from those. And then a sniff test. If you had a hard time creating a seal with your mouth, if you were bulbar progressive, that seal can be challenging, and they can put something in the nose and you can inhale with the nose, and that can kind of give us a little leeway to getting you your respiratory equipment. Although the sniff test hasn't been truly accurate in the past. It's kind of a cheap way to get you what you need. Okay, so subjective symptoms. Over time, you don't realize that your breathing's changing because you're living with this change day in, day out. But there are triggers that everyone should look out for to say, hey, I wonder if my breathing's being compromised or if I'm noticing a change in my respiratory function. That would be, communication, breathlessness with communication, hallucinations. Morning headaches are a huge one. Morning headaches, the reason why we ask that at every visit is because CO2 retention headaches. When we are restricted over time, our lungs, to breathe like this, if you will, they breathe in and out so freely. Over time, the upper lobes kind of inhale and exhale. The lower ones, which have millions of air sacs, you can imagine, that look like plump grapes. Over time, those plump grapes turn to raisins. The membranes get thick, they collapse. You'll hear a word called atelectasis. We need to make sure that you don't have those atelectic air sacs and you're not restricted, because then you're not getting proper gas exchange, inhaling the oxygen and exhaling the CO2. So headaches are a huge trigger. Orthopnea. If you lay flat and you notice that you have to prop yourself up to breathe better at night, or you find yourself sleeping in a recliner, that is a trigger, and that could mean pulmonary compromise. Reoccurring chest infections. You have a lot of mucus and chest, a phlegm, and you're going, what's going on here? It hurts when I deep breathe. That is a sign of restriction as well. Fatigue. If you're not sleeping well at night, waking up multiple times in the middle of the night, that could be your hypoxic drive, which is just like your heart beats. You don't have to think about it. Your breathing shouldn't have to be complicated. You shouldn't have to think about it. So it'll say, hey, wake up. You're not breathing appropriately in your sleep, and it'll wake you up. If you wake up with a dry mouth, you're probably air hungry because you're sleeping with your mouth wide open. You're not getting enough volume because you could be restricted. And then, we're already lethargic with the disease itself, but daytime sleepiness, excessive sleepiness can also be a trigger. So think about those things. The last one that's a really important one, I think, is poor concentration and memory. If you wake up and you feel foggy, you didn't get well rested, you had multiple awakes in the middle of the night, that too can be a sign of restriction and inappropriate gas exchange and lung concerns. Okay, so let's talk about bulbar weakness and secretion management, because I hear a lot about this. I can't express the importance of pulmonary hygiene, getting on a good regimen with breathing exercises, cough assist machine, nebulizers, chest physiotherapy, and we can talk about each of those things. But our mouths are the dirtiest parts of our body. When we have a bulbar onset patient that can't control that saliva or control that, a lot of that we micro aspirate, meaning we put it down the wrong pipe. It goes into our lungs. And that is how we can grow infection. If you are notorious for getting infections, a good oral regimen is very, very important on top of not just, your cough assist and things like that, that your therapist should be proactively ordering for you. Now, sialorrhea treatment. A lot of my patients confuse sialorrhea, saliva control, with chest congestion, or saliva control with how the disease progress is going. So let me just tell you. The first question is your saliva thick or thin? Is your saliva colored or discolored? When you can answer those two things, then we can definitely direct you down the right path. If your saliva is thick, we would know that you're probably dehydrated. We would know it could be the mucus from the chest. We would know if it's colored or not, if you're fighting an infection or not. So to treat sialorrhea, our bodies like swallow, I think, 25 mLs of saliva a day. So the saliva now no longer is controlled by the bulbar region, so a lot of it falls forward. So the medication regimen on that is, if it's thin or thick, we would thicken it. If it's already thick, we can't do that. We want to thin it. We would want to know if we're fighting an infection versus not fighting an infection. But there is always something we can do for it. Don't go, oh my goodness, all this saliva and I don't know what to do. There's glycopyrrolate that helps thicken it. There's hycosamine patches. They're like little circle Band-Aids that go on your neck that help dry it up. Transdermal scopolamine. Botulinum injections, we can actually Botox those, and we can go as far as radiating the salivary glands. So always know, based on which thick, thin, colored, or discolored, we have a regimen and a route. Saliva is a constant battle too. I feel like we're always up and down, up and down. Excess saliva, dry saliva. Don't get frustrated, because it's a continuous battle of finding a good balance. And then in 2 months, we could have a different balance. But in the moment, we're constantly juggling how to control it, but there are alternatives to it. Okay, BiPAP versus NIV. This is the big why. Why is BiPAP, or non-invasive ventilation, so important when so many people battle it? And originally in the beginning, I think they do have a hard time getting acclimated to it. The big why is because, had I mentioned earlier, that hypoxic drive, okay? Our ability to want to breathe in and out is so strong that our muscles that we're trying to preserve will go through strenuous efforts to accommodate your hypoxic drive, your drive to inhale and exhale right volumes to get right gas exchange. Just like you sweat at night when you're hot, or you sweat when you're hot, your body is trying to use its muscles to get the right volume in and the right gas exchange out. Okay. Now, when our hypoxic drive overpowers our diagnoses and says, breathe, breathe, you're not breathing, that motor neuron, that signal is sending to the muscle rapidly. It is saying, breathe in, breathe out, breathe in, use your muscles, use your muscles. And then we're losing our signal to contract our muscle a lot sooner than preserving it. Okay. So when that fires off and fires off, we're actually ruining the motor neuron, the signal, a lot sooner than we want to. We want to be slow and steady. Everything with ALS needs to be in moderation, slow and steady. We're all about preserving the muscles, not wasting them and not losing that neuron. So BiPAP or NIV tricks the muscles, tricks the hypoxic drive, gives you volume in and volume out in a slow and steady pace. So that way it doesn't overexert itself and you lose that signal. Now, is BiPAP right for you, or is NIV right for you? Now, that strictly depends on the patient, insurance, and where they're at with the disease process, okay? BiPAP, you actually own the device after 13 months. You can purchase portable batteries. It only has one mode and it's a little bit less comfortable. The NIV, which is a non-invasive ventilator, it's kind of like the big kahuna versus the BiPAP. It can have dual modes, multiple modes. We can have a shower mode. We can have a mouthpiece ventilation mode where you put a little straw in your mouth and you don't have to wear a mask and it delivers volume in and out. These devices have internal batteries, so you can take them anywhere, anytime. The unfortunate thing is your insurance will never purchase one. They are forever on a rental, okay? Okay, and then there's different designs too. So there's all different types of ventilators. They vary in all different sizes. It depends on the medical equipment company that you go with who provides what, okay? So the next thing I want to talk about is an ER toolbox. This question gets brought up quite a bit. It even gets brought up at the MDA conference that I spoke at recently. What should a PALS patient have in their toolbox for the ER? Also, years back, used to provide these really amazing cards for your wallet. I haven't seen them in a couple of years, but I'm hoping we bring those back because the PALS would keep these cards and it would tell you, even if you're driving, so you're just Bulbar progressive and you were driving your car and you got pulled over, we don't want the officer to think you're drunk because your tongue is weak. So the card, you'd pull out the card and say, hey, this is my diagnosis. This is where I stand. This is what I have. And it was a good, clear, direct guideline for any ER physician to know which way to go about. Bracelets are great as well. I have some patients that use bracelets. Now, oftentimes you hear supplemental oxygen and supplemental oxygen is not good. And why isn't it good? Let me tell you, you do not want a simple fall and you call 911 and they put you on oxygen right away in the box because, you know, they're first responders and they know they're just covering their bases. The problem is with supplemental oxygen, adding a nasal cannula or oxygen to your typical regimen can be harmful because remember, we have restricted lungs and we're not getting the right volume in and gas exchange out. If we put higher concentrations of oxygen into the lungs, we create more CO2. CO2 is what we're trying to expel. So by doing that, putting high amounts of oxygen on an ALS patient, they create double CO2, triple CO2, depending on the level of supplemental oxygen. They go in increments of 4, all the way up to 100%. Now, if we're having 100% oxygen on a PALS, the CO2 levels are going to climb immensely. And then you're in a downward spiral because then they think you're going into respiratory failure and your pH balanced body comes real acidic. And then you're intubated and it's a whole level that we don't want to go on. So it's important that you advocate or have a family member advocate because the doctors don't always know what's best. Sometimes we present like stroke patients to a small ER. Sometimes we, present so differently. So it's very, very important that you advocate or have the card or have the bracelet and you don't want that supplemental oxygen. Okay. And then have something on hand that if you did have to call 911, I highly recommend you go to your multidisciplinary team hospital. There's one at UC Irvine, Cedars. Sinai has a great multidisciplinary team. Bias, Loma Linda, I think is amazing. But make sure that you ask the box or whoever's taking you, if you had to call 911, to take you to your local team's hospital. And then last, I can't stress this enough. Do not let an emergency situation decide what your true wishes are. So often, someone who says, I do not want a trach, I don't want the tracheostomy, it's not for me. They have a fall, they call 911, they can't express their wishes, they go to the hospital, they get supplemental oxygen, their CO2 levels jump, they start acting a little different. So the ER doctor goes, we need to intubate this patient. When we have that hypoxic drive and those muscles are weak, that that, remember, we're inhaling and exhaling and tricking our hypoxic drive. When you get intubated, your hypoxic drive doesn't have to work. So then you lose it. To get extubated, you have to get trached, especially when we have weak muscles. So a simple fall and a wish that you never wanted, you said, trachs are not for me. Guess what? Now you're trached, vented, and in a hospital. So make sure the importance of having your wishes on hand or having a game plan of what you truly want in your card, with your family, with your caregivers, your team. Just know those ahead of time. Okay, to get trached or not to get trached. This is the most personal decision and hardest decision I think a lot of our pals have to make. What I can tell you is whatever you choose, leave no stone unturned, meaning talk about this in advance with your family, your care team. Know every pro and con that's going to come your way. I can't stress, a proactive trach is the best trach. No size or shape is going to change the vocal of your trach, okay? There are different passive valves, which are little adapters to help you speak after you do get trached, should you have a strong voice prior. Some patients are worrisome that if they do get trached, they can lose their ability to speak because the vocal cords will no longer always work. That is a 50-50 scenario. And if you have a strong voice prior to getting trach, the most likely you'll be able to speak after. But if you have a compromised voice, then that's a 50-50 shot. That's why voice baking or getting a Toby Dynavox on board with a proactive team is very important, because communication is so important for our patients. So if you have that and you already are on board with using it and you know the tools you have, then a proactive trach might be best for you. But waiting too long for a trach, the healing process can be tedious. It's about 10 days. Then a lot of these hospitals want to take you to a subacute where family gets trained on how to care for the trach. So you could be in the hospital anywhere from 10 to 15 days to 3 months, if not longer. So it's very, very important that you have a good care team and you know what you want. I do believe, and I'm a strong believer, but getting an early trach early on does elongate your life expectancy when you have that. You breathe easier. It's a straight shot. The machine's going to give you that breath. NIV will do the same thing. NIV, proactive NIV preserves the muscles, but I have one patient who's been on NIV for almost 12 years. Her ears are shot because of the pressure, but she's been on NIV for about 12 years. It does deliver that breath, okay? You're more prone to risk when you're living on NIV, and it's a constant battle with controlling the sialorrhea with NIV. But like I had mentioned, I think it's a very personal decision, and you should know all the pros and cons beforehand. And that's a good hour conversation in itself, just going through it, leaving no stone unturned. Now, a trach does require 24/7 care. You do qualify for more care hours when you have a PEG tube and trach placement. That's very important to some family members. So always keep that in mind. And some people are fearful that once they get the trach, they're held back. No. I've had patients trached on cruises. I've had patients trached on airplanes. I have had patients trached doing whatever it is they want to do. Some just handle it different than others. So once again, it's very personal decision, and it's a long conversation with your care team, your respiratory therapist, and your patient, and whatever it is that you guys really want to take that into what direction. So once again, appropriate decisions truly depend on compliance, motivation, understanding, stating the goals you want to achieve, having the access to the right equipment, billing codes, patient costs, stuff like that. I never want to say a patient couldn't get something because of insurance. And we have a strong strong loaner program that really advocates for our patients and helps them out in so many ways. Once again, you need ongoing technical assistance. Ventilators adjustments need to be done. Toby Dynavoxes need re-education. Once again, you need that ongoing technical team, that CRN team, or that multidisciplinary team always involved. And then it's based on patient and family preference as well. And then it's truly what your wishes are and what your care team can handle. And that's pretty much it. One thing that I didn't touch on that I kind of want to touch on right now is the peg tube placement. I can't stress this enough, and I apologize, it's not in this, but when a patient has a vital capacity, a breathing spirometry test, and it's near 30% or less, and they haven't yet gotten their peg tube placement, they may be at risk of not getting a peg tube placement. A lot of doctors are right now not wanting to place peg tubes because they're afraid that they'll put the patient under. And if the patient never wants to get trached, they shoot themselves in the foot because they waited too long and their respiratory function is too compromised. It is very important that a peg tube placement, a proactive peg tube placement, is put into place. You don't have to use it. You can still eat with oral gratification, flush it, hydrate it, just have it if that's something you really want, because waiting too long could be detrimental.
Great point. Oh my gosh, so much great information, Andrea. Thank you. I certainly learned some things tonight too. And just a reminder to everyone, if you have a question for Andrea, just type it into the Q&A function that you'll see down at the bottom of your screen. We did receive some questions when people registered for the webinar tonight. So I'm going to ask a couple of those first. Specifically, you talked a lot, Andrea, about bulbar onset, but this person saying their loved one with ALS has bulbar onset and has good lung function, but has a lot of problems with laryngeal spasms where she feels like she can't breathe. It's very scary for her. Does this ever become an emergency? And do you ever do a trach for that? They're asking.
It has become an emergency, and they will do a trach for that. And what I'm finding in some of my patients is they get a trach, but they're not vented. I've had a couple that just because you have a tracheostomy doesn't mean you have to be attached to a machine. You can breathe a straight shot through here. But if she's having those laryngospasms, we need to confirm if they're vesiculations or spasms. A vesiculation variants from a spasm. If she's having a bronchial spasm, an albuterol inhaler, which is a Band-Aid, it's not going to fix the problem, and will relax that smooth muscle, open up that airway, and help reduce that spasm. The other thing what she can do, if she has a lot of bronchial spasms or a lot of inflammation from the spasms, irritated soft muscle, Atrovent is another one that albuterol and Atrovent, we call it duo-nib sometimes, those, or sometimes it's called ipratropium bromide. Those two medications together reduce inflammation, open up that smooth airway, and then it can be a fix. But it's a Band-Aid. It's not going to actually fix the underlying problem. So that can be very scary. And that's kind of how we work it. You can nebulize those with a nebulizer, or you can use those again with like an inhalant.
Okay, got it. That's really helpful. Yeah. Someone's asking about machine noises disturbing the sleep of their spouse, wondering if there's anything that could be done to help with that.
So that's a good question, but I want to know, is it the actual machine itself? Is it the alarms, or is it gurgling? Because there's different tricks for each one. If it's the machine itself, I would say let's clean the filter out the back. Okay. Clean the filter. Don't block the fan, but clean the filter. See if that helps. If it's gurgling, it could be condensation or rain out in the tubing from the humidification. Now, they make something called drain bags. It's got a little Y-piece connector. You pop that in and there's a little spout at the end. You can drain those. Or If it's gurgling, depending on the like the room temperature, the atmosphere of the temperature, hot laminar flow through that tube, condensation in a cold room will want to stick to the corrugated tubing. So I want to sew circuit socks if anybody's a good sewer at Christmas time. Put a little sock or tape a pillowcase around the tubing, and that will help with the condensation sometimes. That works. It just depends on the noise, of what noise. And if it's alarms, then we either need to see what's going on. Do we need to increase your alarms, decrease your alarms? Do we need to change your settings? Those are all very, very important things. The good thing is, the beautiful thing is, if you're alarming frequently at night, call the DME company, because they can pull every alarm they see come up. We have a screen with all the history of the alarms, and then we can look back and say, we know what to fix now.
Got it. Okay. Gosh, that's great. And you're right. Maybe that was a pre-asked question. So maybe that person will type something live to clarify.
Yeah.
Separate question. So is non-invasive ventilation like IVAP? This gentleman says, I was on BiPAP originally and 6 months ago asked to change to CPAP, but now my doctor wants me in for a sleep study to check CO2 and do a titration study. He's also had chronic asthma most of his life. He was diagnosed with ALS about 5 months ago.
Okay, so IVAPs, AVAPs, they're kind of interchangeable. And what those types of pressures are, they're volume adjusted and pressure adjusted. They're far more comfortable to be on than a CPAP or just a BiPAP. A CPAP is one continuous positive pressure. You could imagine a straw with a white paper. When you pull that straw out of that white paper, it's flimsy. When you blow in that white paper, it'll stent that airway open. That's CPAP. BiPAP is that stent of air laminar flow. And then it's also a volume that remains in the lungs. So that way you can perfuse better. When you inhale, stenting, if our air sacs are like this and we need them like this, remember raisins and grape analogy. If we have those grapes open, we can breathe better and perfuse better. And then our oxygen levels will stay up high further longer. And that has a better influence than just using oxygen itself. Now, IVAPs, AVAPs, those are a targeted volume we're going to deliver on constant adjusting pressures. So that way you get an average volume that you're requiring to inhale and exhale, but you're not getting the same pressure in and the same stented pressure. You're getting flexible pressures because sometimes I breathe deep and other times I sigh slow or I don't take that deep breath. So it's constantly adjusting and it's far more comfortable.
Got it. Okay. Thank you. And he says very helpful. Thank you.
Mm-hmm.
Just a question in your presentation, Andrea, someone's asking, what's a proactive trach mean?
So you don't let an emergency situation decide for you. If you are progressive bulbar dominant, you're losing your ability to speak and swallow. You find yourself choking on a lot of solids and liquids. Why wait for an aspiration? Why wait until something happens and we're in trouble and you have a pneumonia and we're trying to heal from that? If you fear choking and you have a lot of saliva and you're requiring, a lot of cough assist during the day and it's uncomfortable and you want the trach, be proactive with the trach. We would probably, a lot of these scheduled things are like 3 months out. A scheduled PEG tube sometimes can take 3 months. So if you're noticing bulbar weakness or difficulty swallowing, be proactive. If you're noticing that you're having a hard time breathing and you're choking a lot and the fear of going down the wrong pipe comes in, be proactive. Be that way. Be proactive.
Great. What about smaller BiPAP machines available for maybe traveling? Are there things like that?
So technology is great. And after this wonderful thing called COVID, we've come out with quite a lot of cool stuff. Okay. We're evolving now. They are making, there's a Vivo 65, which is small. It's a really cool small ventilator. There's this one behind me, which is a ventilator, cough assist, suction, oxygen concentrator, although we don't want too much oxygen. You know, it's and a nebulizer all in one. So that's really cool. It's 12 pounds. There's I don't work for them. I got to announce that. I get no benefit from that.
PSA,
yeah. But they are evolving and there are smaller ones. If you're comfortable with your BiPAP, let's say you already had a respiratory issue before your diagnosis and you're really happy on your BiPAP, they make alternative batteries. They're really thin and square. You can, with the humidity built in, they have those. I think I have one I can show you guys. They just really cool, thin little batteries, you know, that is great as well if you needed something like that. There are others out there. Yeah.
Cool. Yeah, you got a lot of tips and tricks behind you. That's awesome. Do you have any suggestions for a bulbar patient with chronic yawning? They're saying likely related to bulbar dysfunction and teeth grinding. It's causing havoc with the seal of the mask.
Yes. So they do make bite blocks, like you can get one at your sports store. We have those if you're not too jaw tight here, you don't have the locked jaw. That sounds like we may need to increase your baclofen. If you're locked jaw and you're not doing well with this, you might need an adjustment in your baclofen. But they do the oral mouse, as long as you're getting the right volume in your nose and the right amount, and your machine will tell us that, you can use that. I apologize. I don't recall what the first part of that question was.
No, I think you got it. Yeah, I think you covered that one. That's perfect. Mm-hmm. What about, do different trach tubes help with breathing and speaking better? Does the size of the suction catheter matter in how effective they are in pulling up secretions on vent-dependent patients?
So that's a great question. The actual trach itself isn't going to assist with vocalization. Now, the reason why we have different sizes of trachs is strictly on the neck. Okay, if you have a bull neck, a rather large neck, then you're going to get a distal longer trach. If you have a short petite neck or a small neck, we're going to give you based on the dimensions of your neck, not necessarily on assisting with vocalization. Now, passing nerve valves in line will help with that if you have a strong voice prior to getting trached.
Okay.
That strictly determines that.
Okay, no, that's helpful. This is an interesting question. My doctor told me that you have to be on a ventilator if you have a trach with ALS. Is that true?
That's not true at all, but keep in mind, we don't want to work too hard on our hypoxic drive and lose our signal. If you're during the day off and you have an HME in place, cool. Stay cool and steady. You're awake. You're taking larger volumes. You're breathing okay. At night, when our breathing suppresses and we breathe more shallow and lighter, guess what? Our muscles are going to be working harder because we want the right gas exchange. And we're not doing that because we're hypoventilating. So at night, I highly recommend you be on it. But during the day, if you're not having any issues, that's okay.
Okay. And what should a person do for excess saliva?
So that's a tricky one because remember, it's a constant balance. Is it thick or thin? Is it colored or non-colored? I would say if it's thin, start your tablets. You put a little tablet on your tongue, and that's like the first line of defense. If that doesn't work, then we'll do the patch, we'll do Botox, radiation. It's a constant juggle with saliva. If it's pouring out profusely, though, and it's thin, we definitely have something for that. If it's thick, you probably need more water. You might be dehydrated, okay? And so we really just need to know the style of the saliva, and then we can really treat it that way.
I don't see any more questions. I want to give everyone just a minute if you have another question to type into the Q&A function. Oh, we just got one. Oh, this same person says Botox patch and tablet didn't work.
Radiation is our next one.
Got it. Okay. Okay.
And you got to come in for that.
That's right. That's right. You know, Andrea, this has been such great information. You know, as I addressed at the beginning of the webinar, obviously these are scary symptoms for people, and this is, you know, changing every day with a disease like ALS. And I think just having information like some of the pieces, the tools in their toolbox that you've given them tonight has been really very, very helpful. Super appreciate you being here. And I really just want to thank everybody who's on for joining us tonight. We're so grateful to each of you for your time and commitment and for being a part of our community. And once again, a big thanks to Mitsubishi Tanabe Pharma America for their support. We have some May events coming up in the month of May in support of ALS Awareness Month that starts next week, actually, on May 1st. So please mark your calendars. We hope that you join us for our next Ask Me webinar, which is scheduled for Wednesday, May 25th, on the importance of multidisciplinary care with the UC San Francisco ALS Clinic team. And we have a fun and inspiring art show event that's occurring on Thursday, May 19th. Please check out that website for more details. And as we slowly return to in-person events this year, we invite you to save the date for the SoCal Ride and Rally to Defeat ALS on Saturday, May 14th. Please join us for such a beautiful day outdoors and sign up today at the website on your screen. Hold on one second before we go to the next slide. I did get a quick question here, Andrea. I just want to make sure we're answering it. What's your opinion on the vest versus the cough assist?
That's great. And I'm going to tell you guys a trick. If you are bulbar predominant and you're proactive in getting your trach, get your cough assist. And then at the 12th month, say it's not working anymore. Say you need to DC this order and get the vest. That's the trick. Because after the 13th month of insurance, you own it. And after you get trach, you're going to want your vest. So if you're bulbar predominant, use it, keep your lungs open, clear, and then at the 12th month, keep in mind that you're going to DC it because you don't want to be stuck because you get one or the other for 5 years. So DC it and then get on board with getting your vest because sometimes your trach is sensitive and it's hard to pull the cough, inhale and exhale from the trach. So keep that in mind. Or if you want to get the Voxin, the 5-in-1, and that's something you really truly want, they won't give it to you if you shoot yourself in the foot and get a cough assist or a vest before you get your NIV. So that's kind of a troubled one too. You got to kind of tailor it and think far in advance of where you're going with the disease because no two people look the same, and then have a good game plan. And you could always email me and ask me and I will help you. But having a long game plan, a short-term goal and a long-term goal is kind of really important because you always might need one or the other down the road. And the guidelines are kind of silly.
That's good. That's great. That's great. That makes sense. And just slightly off topic real quick, someone's asking, are there breathing concerns in traveling to high altitude locations? This person uses a CPAP.
Now, that's a good question. Planes are pressurized, so oxygenation isn't too bad of an issue. Also, because if you're using your cough assist and you're proactive and you're opening up those air sacs, oxygenation isn't the problem. It's getting the volumes in and out. So typically, depending on how high you go and what altitude you go, you shouldn't have that issue.
Got it. Okay. And just last question, what is restrictive ventilatory defect with ALS?
So that's also known as restrictive lung disease. What that is your air sacs, the volume you should carry based off your height, weight, age, ethnicity is, let's say, 3 liters of air on inspiration. But because the muscles are weak, Now you're only breathing in 1 liter of air. That would be considered restrictive ventilator disease, restrictive lung disease, because we're no longer inhaling and exhaling the right amount of volumes. And that's kind of where this whole inhale and exhale proper gas exchange comes in, because it's so important. That's why breath stacking and getting deep breathing exercises on board, so that way down the road, your lungs are open and clean and clear and your air sacs are open. That's what bronchial hygiene really, really is so much about, is because if you do that in a proactive way, your vital capacities, the amount in and out, will remain larger if you're on board with a proactive regimen.
That's great. Thanks so much, Andrea. And I know we've had a couple questions tonight, just wondering if you'll be able to receive the link to the recording of this webinar, and you absolutely will receive that in the follow-up survey email that you get when we're all finished tonight. So I know we went in a little bit of reverse order here, but thanks so much, Andrea. I wanted to make sure we got those final questions answered. So again, yeah, thank you so much. And, please, everyone join us for the ALS Awareness Month events coming up in the month of May. We'd love to have you participate in any and all of these. And as you know, fuels everything we do, and we're grateful to committed donors who give generously throughout the year. To learn more about how you can support the valuable programs that we offer, like this one tonight, please visit our website at give.alsagoldenwest.org. And please watch out for that short survey on tonight's presentation that you'll receive with the recording to the web